Hey everyone, welcome back for another deep dive. As medical microbiologists, we're all pretty familiar with Melioidosis, but today we're going beyond the basics.
That's right.
We're going to uncover some really cool stuff about this, Great Mimicker, as they call it.
Absolutely.
And we're going to be using some great sources today, like Microbiology, the CDC, and Microbe Canvas.
Great resources, really interesting insights there.
Yeah. And one thing that really caught my eye was this whole Vietnam time bomb phenomenon.
Yeah, it's fascinating, isn't it, how an infection can, lay dormant for years and then suddenly reactivate. It's kind of scary, actually.
Yeah. So before we get into all that, let's just start with the basics. What exactly is melioidosis?
Well, it's a potentially serious infectious disease, and it's caused by this gram-negative bacterium, Burkholderia pseudomallei.
Okay.
And this bacterium, you find it in soil and water, mostly in Southeast Asia, northern Australia.
Interesting. So it's got like a pretty specific geographical preference, huh?
Yeah, it does. And, it makes you wonder how these distributions might change, like with climate change and stuff,
Yeah, that's a really good point. Something to, keep an eye on for sure. But getting back to melioidosis itself, I know it can present in a bunch of different ways.
It can. You have the acute form, the chronic form, and even a latent form.
Wow. Okay. So let's break those down one by one. Starting with acute melioidosis, what are we looking at in terms of symptoms and how quickly does it develop?
Well, with acute melioidosis, it can be pretty quick. Typically, the incubation period is somewhere between 1 and 21 days.
Okay.
But there are cases where symptoms show up in just 24 hours.
Wow, that's really fast.
Yeah, especially after something like near drowning.
Oh, wow. So why is it so difficult to diagnose in those early stages?
Well, it's the symptoms, really.
Yeah.
They're all over the place. You can have fever, pneumonia, abscesses, even sepsis.
Oh, gosh.
It can mimic so many other things.
Yeah, I could see how that would be a real challenge for clinicians trying to, figure out what's going on.
It is. It really is. And then you have chronic melioidosis, which has its own set of problems.
So chronic melioidosis, that's when the symptoms last for a while, right?
Yeah, we're talking more than 2 months.
Okay.
And this is where the whole mimicry thing really comes in. Chronic melioidosis, it can look a lot like tuberculosis.
Oh, really?
Yeah. It's actually sometimes called Vietnamese tuberculosis.
Huh. I've heard that term, but I never really put two and two together.
Yeah.
That makes a lot of sense.
Yeah. It really highlights how important it is to keep melioidosis in mind, even when a case seems like it could be something else entirely.
Yeah. Absolutely.
Right.
And then there's the whole latent infection thing, which is really kind of freaky.
Wait, the Vietnam time bomb?
Exactly.
You had all these soldiers exposed to pseudomallei during the war, and then years later, sometimes even decades later,
Yeah.
they start developing symptoms.
It's crazy. It's like this bacteria can just fight out in your body for years, just waiting to, strike.
It really is. And it makes you realize, taking a thorough patient history is so important.
Yeah, for sure. Especially, if they've traveled to those endemic areas.
Absolutely.
Wow. So we've got this bacterium that can hit you fast, or it can hang out for months, or it can just chill in your body for decades.
It's a master adapter, that's for sure.
That's incredible. So before we get into diagnosis and all that, I'm just curious about the name melioidosis. Where does that come from?
Oh, it's kind of an interesting story, actually.
Okay.
It comes from the Greek words for a distemper of asses.
Really?
Yeah, because the symptoms in animals, they thought it looked like glanders, which is another bacterial infection. That one mainly affects horses and donkeys and mules.
Oh, okay. That's fascinating. It's amazing how these historical connections can, shed light on things.
It is, isn't it?
Yeah. Okay, so we've talked about what it is, the different forms it takes, even where the name comes from. But how do we actually go about diagnosing this thing?
Well, the gold standard, so to speak, is culturing B. pseudomallei from a clinical sample.
Okay. So blood cultures, sputum cultures, urine.
Yeah, all of that. And, depending on the symptoms, maybe throat swabs or any pus that's been aspirated, gotta be thorough.
Right, of course. And I imagine, given how nasty this thing can be, you have to handle these cultures pretty carefully, right?
Absolutely. Safety first. We're dealing with a potential biohazard here.
Right. And do you need special media to grow it?
You do. You start with the regular blood agar, but you also want to use a selective media, like Ashdowns or Burkholderia cepacia medium.
Okay.
Especially for cultures from non-sterile sites.
So it's not as easy as just swabbing something and waiting to see what grows.
No, it's a bit more involved than that.
Gotcha. Now, what about imaging? Can things like X-rays or CT scans help you diagnose melioidosis?
They can be helpful, yeah. Especially for seeing how extensive the disease is, where it's spread.
Right.
But they can't give you a definitive diagnosis.
Yeah.
You still need that culture confirmation.
So imaging is more of a tool to see the damage, but it doesn't tell you who the culprit is.
Exactly. Good analogy.
I'm full of them. What about abdominal imaging? Is that important given that it can cause those abscesses?
Very important, yeah. Because those abscesses can be tricky. They don't always cause symptoms.
Oh, wow. So even if a patient doesn't have any abdominal pain or anything, you'd still want to image their abdomen just in case.
You would. Better safe than sorry.
Right, of course. All right, so we've covered the basics of diagnosis, but there's still so much to talk about. Luckily, we've got plenty of time to dive into prevention, treatment, and even the bioweapon potential of B. pseudomallei.
Oh, fascinating stuff.
Stay tuned, folks. Things are about to get even more interesting.
Before we move on, I think it's really important to emphasize that early diagnosis is so crucial.
Well, absolutely. I mean, we've talked about lab confirmation and all that, but are there any, early warning signs that clinicians should be looking out for?
Well, we already mentioned travel history, but it's worth repeating.
Right.
Asking patients about recent trips to Southeast Asia or Northern Australia, even past trips, that can be really valuable, especially because of that whole latent infection thing.
Right. It's like you said, it can reactivate years later.
Exactly.
But even with a good travel history, those symptoms are so general, it must be really tough to catch it early.
It is. Fever, cough, pneumonia, those could be signs of so many different things.
Yeah.
So how do you know it's melioidosis and not something else?
I guess you really have to have a high index of suspicion, especially if the patient has those travel risk factors or other things that might make them more susceptible.
Exactly. And once you suspect it, you got to move fast with the testing.
Time is of the essence. So let's say you've confirmed a case. What's next? How do you treat it?
Well, treating melioidosis, it's a long game. We usually take a two-phase approach.
Okay.
First, there's an intensive phase to really knock back the infection, and then there's a longer eradication phase to prevent it from coming back.
It's like a 1-2 punch.
Exact.
What kind of antibiotics are we talking about here?
For the intensive phase, you're going to go with intravenous antibiotics. Ceftazidime and meropenem are good choices.
Okay.
They work pretty well against B. pseudomallei.
How long does that intensive phase last?
Usually at least 10 to 14 days.
Okay.
But it can be longer, depending on how severe the infection is and how the patient responds.
So a pretty long course of IV antibiotics.
It can be.
And then once they're stable, you switch to the eradication phase.
Right. And that's where oral cotrimoxazole comes in.
Okay.
They take that for several months.
Oh, so we're talking weeks, maybe even months of treatment. That's got to be tough for patients to stick to.
It can be challenging. That's why it's so important to communicate clearly with the patient. Make sure they understand why it's so important to finish the whole course of treatment, even when they start feeling better.
Yeah, a little encouragement probably goes a long way, too.
Definitely. Now, speaking of challenges, there's always the issue of antibiotic resistance.
Yeah, that's a concern with so many infections these days. Is B. pseudomallei resistant to a lot of the antibiotics we use?
Well, the good news is it's still susceptible to most of them.
Okay.
Including ceftazidime, meropenem, and cotrimoxazole. But we have seen some resistance popping up.
Oh, really?
Yeah, in certain areas.
So it's something we need to keep an eye on.
Absolutely. Antibiotic stewardship is crucial. And of course, we can't forget about the diagnostic challenges we talked about earlier.
Right.
Missing that diagnosis early on can make treatment a lot more complicated.
It all comes back to awareness, doesn't it?
It really does.
Making sure healthcare providers know about this sneaky little bug.
Exactly. We need to get the word out.
What about research? Any promising developments on that front?
There are, actually.
Oh, good.
Some really exciting research going on right now.
Okay.
Scientists are working on new diagnostic tests, like rapid molecular tests that could identify B. pseudomallei much faster.
That would be amazing. No more waiting for those cultures to grow.
It would make a huge difference. And they're also looking into new treatments, new antibiotics, even immunotherapies.
So there's hope for even better ways to fight this thing in the future.
There is. Oh, and we can't forget about vaccine development.
Oh, right. A vaccine for melioidosis would be huge. Where are we at with that?
There are a few candidates in the pipeline.
Okay.
Some have shown some good results in early studies, but it's still a long way off before we have a vaccine that's ready for prime time.
It's a tough process, but it would be so worth it.
It would. It could protect so many people, especially in those endemic areas.
Yeah.
So yeah, there are challenges, but I think there's a lot of reason to be optimistic.
I agree.
We're learning more all the time.
Right.
And with research and collaboration, we can definitely make progress.
You know, it's not just about the science itself, it's about working together to actually put that science into practice.
Exactly. And as medical microbiologists, we're right in the thick of it.
We are. We've got a really important role to play.
We do. Identifying these pathogens, figuring out how to control them.
It's a big responsibility.
It is.
You know, it's amazing to think that these tiny little organisms can have such a huge impact.
It really is.
Well, I think it's time to wrap up part 2 of our deep dives into Melioidosis. But don't go anywhere. In part 3, we'll be taking a closer look at Burkholderia pseudomallei itself.
It's a fascinating bug.
Dude.
So we've talked about the disease, we've talked about how to diagnose it, how to treat it, but let's talk about the bug itself for a minute. Burkholderia pseudomallei. This is one tough bacterium.
Yeah, it really is. I mean, it can survive in so many different environments. Soil, water, even on medical equipment.
Right. It's incredibly resilient. And, it can even tolerate some disinfectants like iodine, chlorine, things like that.
Yeah, I remember reading that. It can actually survive pretty high concentrations, which is kind of scary.
It is. And then you add in the fact that it can form biofilms.
Oh, yeah, those biofilms like we talked about before, right? Those little bacterial cities.
Exactly. They're like these protective fortresses that make the bacterium much harder to kill.
Right.
And pseudomallei is really good at forming biofilms.
So that's part of what makes it so difficult to get rid of, huh?
It is. It's one of the reasons it can persist in the environment for so long, and it makes treating infections a lot more challenging.
Now, what about the genetic diversity of B. pseudomallei? I know different strains can be quite different from each other.
They can. You see a lot of variation in virulence, antibiotic susceptibility. Some strains are much more likely to cause disease than others.
Wow. So it's not just one, static enemy we're dealing with?
Nope. It's constantly evolving, adapting. Makes it tough to develop a one-size-fits-all approach to treatment.
Yeah, and I imagine that makes vaccine development really tricky, too.
It does. Finding a vaccine that works against all the different strains, that's a big challenge.
It's like trying to hit a moving target.
Exactly.
Well, this has been a really fascinating deep dive. I feel like I've learned so much about Melioidosis.
Me too. It's such an interesting bug.
And to all our listeners out there, thanks for joining us.
Yeah, thanks for listening. We hope you found this deep dive informative.
And remember, folks, stay curious, stay vigilant, and keep exploring the amazing world of microbes.